one of the things that's come up often in my discussions with others is really this question about, are the current AI development sustainable? Do we really have a sustainable pipeline for AI development in healthcare? What do you think about that?
Well, the short answer is no. And, we got to unpack that a little bit. The way sort of AI came around, it's been in academia, it's been around for decades. The first supercomputer for AI in medicine was on Stanford campus in 1984. And the kind of thing that Atropos Health does that you just mentioned, a doctor imagined doing it in 1972. Mm-hmm. So it's been around for a while. But, mostly in research settings, limited deployments, and so on. And then the things that people come up with in terms of how thou shalt do good AI are designed for that phase. And now, I'm sure you and others know that the steps that get you from 0 to 1 are very different from those that get you from 1 to 10 and are very different from those that take you from 10 to 100. And so what's happening is that procedures, rituals, behaviors that we honed in academia to go from 0 to 1 are being applied to go from 1 to 10. And so concretely, if you follow all the great guidance on how thou shalt build and validate a good classifier, and I did a review on that with a student several years ago, there are like 220 pieces of guidance on how thou shalt build a good model. About half of them are about the model and practically nothing on how to evaluate utility, for example. And if you followed all of that, a single model would cost you anywhere between 6 to 10 years and about $28 million to build and validate and prove that it works. Mm-hmm. We can't sustain that. There's 123 residency and fellowship programs on our Stanford campus. I'm sure other universities have similar. And if one person in every discipline wanted to build and validate one model at that level of burden and cost, we just can't afford it. AI is supposed to reduce healthcare costs. And so the point is that we as a community have to figure out that, all right, the 0 to 1 got us to the proof point that, yeah, these things kind of seem to work and will help, but what are the behaviors and setups and rituals we need to go from 1 to 10 and 10 to 100?
So is part of what you're talking about here kind of the regulatory framework? I understand almost in many ways the history, like we've grown up and AI has been, since the very beginning of my career, 25 years ago, it's been a topic of one sort or another in machine learning models and algorithm development, et cetera. And I think the scientific and methodological evaluation of these models, and I always think of the model bake-offs that we had in different areas. One of the things I worked on were models in diabetes and cardiometabolic disease, and we had bake-offs with competitors and a national symposium to compare models to each other. But if we're talking about healthcare, and to your point, being really efficient about the delivery of the model to the patients, does that mean we need to rethink what that framework is? Do just many of these rules not apply, or do different rules apply?
I think it's not just about regulation. It's a great question. So, for example, imagine driving. Mm-hmm. Personal transportation using automobiles, like that narrow part of driving. Okay, it's great to build a car and have its engine tested and all of that. But in order for people to safely drive around, and my 16-year-old just got his driver's license, so like I'm very into it right now. There's some federal standards like EPA, National Transportation Safety Board. We do crash testing, FTC gets involved. There's a whole bunch of federal regulation about cars. Then there's building of highways and making sure that the roads are up to standard. Then there's consumer reports and KBB and JD Powers and so on. But before buying a car, we still go do a test drive. And then once after the test drive, we purchase the vehicle, you still have to maintain it and do your annual registration and smog check. And we need traffic lights and police and so on. So I think in AI, what's happening is that people are looking for that one thing that's going to solve AI in healthcare. That's not going to happen that way. It's an ecosystem play. And everybody has to sort of figure out, what's within scope. Like regulation obviously has its scope, but that's not the start and end. Like if the FDA evaluates something and says, yes, it's a good model, that decision is as that day. Now, when you apply it in your health system, like you do have to, going back to driving, do your annual smog check. And you do have to change the brakes and maintain the tires and stuff. And so I think what we have to think about is what are the rules and responsibilities of every constituent? What is under the government's jurisdiction? what is onto the provider, what is onto the vendor, what is onto the insurance companies, what is onto the end users. Like if the end user finds some errors and do not report that, like the vendor can't fix anything.
Yeah, you bring up an interesting point, and I love the driving analogy because I always think of like who's responsible for the AR car crash, right? Is it the person who ran suddenly into the road in like some random, act, or is it the AI company that didn't build the software processor to recognize that it's happening? And so I think there's a lot of kind of question in my mind around kind of who holds the bag, the liability for all of this that I think is an impediment. I actually think we have to continue to work through it. There's another element to what you're talking about, which is something we actually, my company and I have worked on for a while, which is with AI and with the new technology that we're coming on, especially with the speed with which these models can evolve and the changing situations that they're in, meaning to your point, you might validate it in one situation, but then expose it to another. How do we think about the idea that models change and learn over time? And how do you kind of manage the fact that the model that I have today is going to learn from whatever happened today and is going to be different tomorrow? And what are the kind of guardrails we should be putting around that type of kind of continuous improvement? And how do we judge it?
Another great question. At least the way I'm thinking about it now is this idea we call local validation and continuous local validation. So again, using our car analogy, just because a self-driving car can drive in Palo Alto does not mean it's going to work in Mumbai. You got to test it in Mumbai. And just like in that same setting, people are creating cities that are giving permits for self-driving cars to drive around. Like Waymo's drive around in San Francisco, but not yet in San Jose. Well, San Francisco stands to gain from that. So similarly, in case of AI models, we will have to create two things. One, safe spaces where we can start testing, where we can refine how can local monitoring be done, continuous local monitoring. And once that's figured out, devise ways that the ability to do that kind of local monitoring can be shared broadly. And for example, if you start using something and your model's updating, you are still making decisions based on the models. And by that click, the user is telling you whether the model's decision was quote unquote right or wrong. And if we create a rolling data set over a sliding window of a month and always back test our models, we can very early detect if there's a substantial change in the behavior. But right now, it takes us a minute to articulate this, but putting in place this capability in the software where the models are running, we don't have that capability yet.
Yeah. It's almost like the guardrails, or I think of them as bumpers. You want to see when the ball hits the bumper that there's some sort of alert or alarm at least that goes off. Otherwise, one of the things I've just thought about and worried about is like when things change slowly over time, like there's this almost like the bias comes with you, right? Mm-hmm. So if it's not a dramatic change and there isn't a specific change in pattern, it's very easy for like errors to start propagating, right, in a system. You don't even realize how far you've gone. It's a little bit like, you think you're going in a straight line, but you're actually not quite going in a straight line. And suddenly you find that you're many degrees off course or not. And so I love the concept of I think of it like a local testing harness, right? Mm-hmm. Which requires the establishment of some set of truth or data about the locality.
Correct. And one more thing. Mm-hmm. To your point about, gently veering off course and not realizing, upfront, we have to define what is our presumed benefit. And that local validation should always check. Are we going towards the presumed benefit? Or are we going away from the presumed benefit? So we can detect these drifts that, mm-hmm. This thing is like, yes, it seems to work. Performance is great, but we're not really getting the impact that we hoped. Mm-hmm. Turn it off. Don't renew the license.
And so when we think about that, maybe just to clarify for listeners, when we think about localized, are we talking about in medicine, clinical relevance? Like I think of cardiology versus oncology. Are we talking about, Stanford versus community setting, right? Are we talking about, Chicago versus New York? Like,
what is the unit of analysis? No, it's another great question. I don't think it's clear right now. So let's say something pedestrian, something simple, like a readmissions model, right? The way in which a cardiology group discharges a patient versus the way an orthopedic surgery group discharges a patient is very different. And what you do about the readmission also depends on what they are readmitted for. If a person with a knee replacement complains of pain in the knee and fever, the burden to do something is much higher than perhaps some other situation. Mm-hmm. And so I think what this gets to is like, what is the context in which we evaluate? And I think that definition of the context of use is going to be inherently by the end user. Again, how you drive your Tesla might be very different from how I drive my Tesla. Mm-hmm. And that context affects the wear and tear, the behavior of the vehicle, and all of that. And so while it's tempting for everybody to aspire that, can't we not have like one validated readmission model that works everywhere? I don't think that's going to happen. I don't think it's even reasonable, because who is going to do what based on the model output is inherently a local decision. And that scope defines your context. And sometimes it's by clinic, sometimes it may be by county, sometimes it may be by health system. Sometimes it might be based on like other concerns that like the business unit that is doing it. And maybe the same clinic has two practice groups working in it, and they have two different business models and hence two different workflows.